Hi guys, welcome back. The next topic that I'm going to teach you is tuberculosis. And since it is primarily a droplet based transmission, for any droplet based transmission infection, we should be knowing regarding the RO number. You see, when you look at RO number, RO basically would mean the reproductive period for any infection per se. Then for COVID-19, the initial report that came from Wuhan, where the disease actually spread, it was documented the RO number was 2.56, that one case will infect these many number of patients. Subsequently, the disease spread due to Chinese tourists to Italy, and the data that was coming from Italy in March 2020 was about a RO number of 7. It is that value of RO of 7 that actually sent the Indian government into a panic mode, and the government of India introduced a lockdown in March 2020. But subsequently, it has been documented in Indian reports that the RO number of COVID-19 is something in the range of 1.29, and our objective with respect to COVID-19 will be mainly to bring it to less than 1, because that is when you break the chain of transmission. Well, when it comes to COVID-19 pneumonia, I want to highlight the radiological finding is always GGO, that is ground glass opacities, which are mainly found in the lower lungs bilaterally. In fact, for non-medical people, whenever I talk about COVID-19, because they are not going to take me seriously, I always say the word, it causes double pneumonia. You see, from a non-medical's perspective, when you highlight the word double pneumonia, they at least take you seriously, because most people have this impression that it's only going to cause a cough and cold and will gradually go away. In case contrast, tuberculosis will definitely cause lung destruction and can even cause a cavity formation. If you look at this X-ray per se, you will notice that in the right upper zone of the patient, there is a very distinct circumscribed space that would be a lung cavity present. And how much is the RO number for tuberculosis is again a problem even now in India. I mean, why we have not been able to eradicate this infection, though we have been trying for so many years with our tuberculosis control program and revised tuberculosis control program, is because the RO number even today stands at 1.2. I would like you to basically take RO numbers that I've told you pretty reliably, but if the PSM teacher is giving a different RO number for what I have said, then I would like you to follow the PSM teacher. This is what I've said for COVID-19 as of now towards the end of 2020. The value given is 1.29, and for tuberculosis it is still 1.2. So we have not been able to handle these infections as well as we anticipated, primarily because if you want to break the chain of transmission, the RO number should go to less than 1. Infections like measles, infections like smallpox, they were having RO number even higher. In fact, for measles even in chickenpox, the RO number can go in double digits as well. You see, the case fatality rate of smallpox was higher, so it was obviously, a concerted effort was made to introduce a vaccine for it, and we were able to eradicate it. But it's still a long way to go as far as COVID-19 is concerned. Now I will focus mainly on the aspects of pulmonary tuberculosis. Imagine a person of tuberculosis is coughing right on your face. You are anyway aware of the fact how our patients treat masks. I mean, the mask will be, below the level of the jawline half the time, and you have to actually ask them to pull up the mask. And suppose a patient of pulmonary TB is coughing on the face of an intern. Where will the TB bacteria land out of sight 1, 2, and 3? Then please remember that usually the site is going to be either the lower part of the upper lobe or upper part of the middle lobe if it's the right lung. So the site for primary tuberculosis, mark my words there. If they say what is the site for primary TB, where will the TB bacteria land in, it would be answered by you as the lower part of the upper lobe. This will be the site for Gohan's focus developing in the lungs of the patient. Then what about the apex? Apex, guys, is a site for reactivation of tuberculosis. So lots of time you will read the word written post primary TB, or instead of post primary TB he might say secondary tuberculosis. So the words to be remembered are post primary TB slash secondary TB slash reactivation of TB is what is going to be located in the apex per se. But as I asked, if a person is coughing on you, where will the TB bacteria land? Then there are two possibilities. Either it will land in the tonsils, or it can go in the airways, and if it will go in the airway, it will mostly be in the lower part of the upper lobe. That's the primary site of Gons focus. Unfortunately, I said Gons focus can also be developing in the tonsil of a doctor. As a result of it, this particular chap will start developing cervical lymphadenopathy. So I have handled one more MCQ. What is the common site of extrapulmonary tuberculosis? Then the most common site of extrapulmonary TB happens to be cervical lymphadenitis, and you would have seen lots of such cases in your outpatient departments. These lymph nodes can become bigger and can even burst, and the pus will then escape into the soft tissues in the neck, and the person will end up with development of a cold abscess. If there's a cold abscess, I definitely need to treat it by giving anti-tubercular treatment, but I will not do a incision and drainage, because if you do a incision and drainage, guys, this pus contains live TB bacteria. If you give an incision over a cold abscess, this pus which is containing the live TB bacteria, that will seed the area where you gave the incision, and there could be a fistula formation at the site of IND. So normally in abscess we always go for incision and drainage, but in this case we are going to put in a needle and we're going to drain the abscess, and we are not going to put the needle from bottom, because normally the teaching in surgeries, whenever there's a swelling in the body, you put a needle into the swelling from bottom. Here you will be putting a needle into the swelling from the top. So it is actually gonna be an anti-gravity drainage. Mark my words there. If you are gonna be treating a cold abscess alone, ATT is not gonna work. It's gonna be evacuation of pus using anti-gravity drainage. That will reduce the chances of fistula formation because you're putting needle from the top. And along with that, obviously the standard ATT for 6 months has to be given for management of extrapulmonary TB. Three concepts that I've highlighted is what is the site of primary TB, what will be the site of post-primary TB, and extrapulmonary tuberculosis. Well, how would it be handled? Now let us just recap what really happened here. So I'll just take it on myself. Like, I'm sitting in the OPD, a patient came and coughed on me, and the TB bacteria has landed in this area, that is lower part of the upper lobe. Now because of the bacteria landing here, I will definitely be having a reactive lymphangitis, and the lymph nodes in my chest on that particular side will become engorged, and they will obviously be having seeding of the bacteria as well. So in this diagram, I have now shown the red dot is representing the Gons focus, but there is a concomitant same-sided lymphadenopathy as well. So I've highlighted a Gons complex at the moment. Gons complex will develop after a Gons focus. Most of the time, Gons complex patients will be asymptomatic, but there's a but also. The word but implies that sometime the Gons complex can actually be located subpleurally. Now, because of the peculiar location, it is present towards the periphery subpleurally, so it can irritate the pleura, and irritation of the pleura can contribute to development of pleuritis in the patient. So, though most of the patients are asymptomatic, don't be surprised if you read Gons complex being associated with fever and pleuritic chest pain. The chest pain will worsen on deeper inspiration. In fact, at this point of time, he might even talk about skin lesions like erythema nodosum, which will develop on the shin and would be painful. And apart from that, he might even talk about phylactenular conjunctivitis. That would be reaction to the tubercular bacilli, the proteins which are present in the tubercular bacilli. So the message is that once a person is exposed to tuberculosis, the immune system will kick in, and that will contribute to Gons complex. Now, assuming that this person is having a good immunity, I'll give you two scenarios. One will be good immunity, second will be bad immunity. I put it on myself. I was working in a tertiary care hospital. I obviously was exposed to TB, but I did not develop pulmonary tuberculosis because my good immunity controlled the infection, or it contained the infection. There was a containment zone created. This is what I'm saying. This was the focus, the red dot. This was lymphangitis. Then I had developed a unilateral hilar lymphadenopathy, which is now teeming with tubercular bacilli. So I've just put some dots here to highlight the bacterial load. And now my body is going into a containment mode, which is that there will be a development of calcification around the focus, and there's going to be calcification around the lymph node as well. So you can notice that now what is happening in the patient is that there's a definitive calcification at two sides, at the focus as well as at the lymph nodes as well. And what you are having now developing in the lungs of this person of relatively good immunity is Ranke's complex. Since I was giving example of myself, guys, if I take a chest x-ray of mine, my x-ray shows multiple white calcified spots. Obviously white means calcified only. My x-ray shows calcified spots. Why? Because during my residency I was exposed to TB, but I did not develop TB. One of my colleagues did. I did not develop TB because I had was a good immunity. So there was a development of a calcification which resulted in containment of infection, and gradually the multinuclear giant cells destroyed this tubercular bacteria. So as such, I never came to know what really happened unless and until maybe when I applied for one of the jobs, a government job, that is where medical checkup was done and my x-ray showed multiple calcified spots. So I was staring at the x-ray saying, what are these spots? And then I realized that this could be primarily because of the fact that I was exposed to tuberculosis. But in some cases, people may not be so lucky. So I'm going to give you version 2 of the same data. A person has been exposed to TB. Let us say this is a young doctor. He has been exposed to TB. Let us see what can happen with respect to the lungs of this guy. This is the same focus. This is the lymphangitis. This is the unilateral hilar lymphadenopathy, which is increasing on day-by-day basis. But since in this particular chap, the cell-mediated immunity really did not kick in as it should, so therefore there can be multiple problems developing in this person. One of the problem can be that this disease can actually increase in severity because his immunity is not kicking in. The disease can increase in severity, cause local destruction, and therefore you could be having a cavity formation. There is also possibility that the subpleural location of the Gons complex could actually result in development of a full-blown pleural effusion developing in a patient. In fact, some cases the lymph nodes will increase in size substantially, and the enlarged lymph node will be compressing on the airways, causing a ball valve effect. To explain the ball valve effect, I can say like when you fill the air in the tire of a car, air goes in but cannot come out. Similarly, the ball valve effect can definitely come in, and that is why you can read the word lobar inflation. This is because air can go in the airways but obviously cannot escape. In some cases, there might be complete obstruction, like there's total squeezing of the airway by the enlarged lymph node from outside. Then no air will go inside. If no air will go inside, he will write the word segmental collapse. So what I am teaching you at the moment is actually written in the textbook as primary progressive pulmonary TB. In some cases, there might just be development of a patch in the X-ray, just like a patch that you might see in an X-ray of a person of COVID-19, or maybe a patch that you might encounter in a community-acquired pneumonia. So I'm just writing the word tubercular pneumonia can also develop. All these manifestations, guys, that I've explained to you would occur in those people who are exposed to TB and their immune system does not kick in. So this would be primary. Mark my words, there secondary TB has still now not come on the radar, still not on the discussion. What we are talking about at the moment is progressive pulmonary tuberculosis, but the words are double P before it, that is primary progressive pulmonary TB. In secondary TB, the word written will be post primary TB. So the message at the moment is, if somebody gets exposed to this infection, if he has a primary Gons focus developing in his lung, depending on good immunity or bad immunity, two scenarios are possible. Good immunity, we will have calcification, containment of infection. If a person has a poor immunity, then any of the 5 manifestations can occur, and most of the time in clinical practice you will encounter pleural effusion developing even in primary tuberculosis. I have today taught you pleural effusion developing both with respect to, I mean, it will obviously occur in secondary TB, no doubt about it, but even in primary tuberculosis there can be a possibility of development of pleural effusion, and these terms like lobar inflation, segmental collapse can occur, and that depends on the mass effect of the enlarged lymph nodes. If it is going to completely occlude the airway, there would be segmental collapse. If it partially occludes the airway, allowing air at least to go in because diaphragm is powerful, then there could be a lobar inflation developing in the patient as well. Now, as I explained to you that I during my residency was exposed to tuberculosis but did not develop pulmonary TB per se because my immunity kicked in, I'm just recreating that status of myself here. This is the focus, lymphangitis, enlarged lymph node, and in color green I have shown the calcification present. You see, once TB bacteria are present anywhere, you will have a tough time, or the security system will have a very tough time killing these bacteria per se, because they are pretty tough to kill. In fact, in the lymph nodes, they might live for good as long as 5 years. This is the situation of me. There was at least bacteria present in my lymph nodes for substantial duration before my immune system actually was able to destroy it. But suppose if my immunity decreased while these bacteria were proliferating inside my lymph nodes. If there was a decrease of my immunity, I'm not saying that I could have acquired HIV or AIDS. I'm saying maybe a bad case of typhoid. If my immunity decreased, though there is a calcification, but still now the infection can spread out of the lungs. What I'm teaching you now is a scenario of reactivation of tuberculosis. So a person who has been exposed to TB, let me say during his residency, he may not develop features of tuberculosis immediately because the immune system kicked in. But later on, if his immunity decreases due to any reason, there can even be a reactivation of TB, guys. In fact, most of the cases of adult tuberculosis are like this only, that they're exposed to TB earlier. Initially, the immune system responds, but later when the immunity tends to be lesser, that is when there can be reactivation of TB. So the majority of MCQs that you will get in the exam will basically use this term, post-primary TB. So I want you to be very comfortable with the terms primary progressive pulmonary TB, where the immunity is bad, so straight away manifestation. Second possibility, initially no problems because calcified spots will develop in the X-ray, but then the infection can spread also. And once this infection can spread, this infection will tend to go supraclavicularly. which can contribute to development of a supraclavicular focus developing in the lung, that is Puhl's lesion. Please remember, Simon's focus is not to be answered at the moment because Simon's focus is inactive. We are talking about an active lesion in the area which I've highlighted as 1, that is supraclavicular, so that is Puhl's lesion, and area number 2 that I've written would be called as Assman focus. These are itself questions, no, like you are familiar from your even pathology classes that which focus is found in tubercular meningitis. Similarly, Puhl's lesion and Assman focus are found in post-primary TB / secondary tuberculosis, and half the time it is the terminology which bothers us more. In fact, for the focus, since lots of questions are asked, I would just like to mention some historical data which is very clear, because TB bacteria can be seeding even blood vessels. So if there's a focus in the pulmonary vein, then we tend to call it Wiegert's focus. This is additional information which you can, I would suggest you, in fact, even if you are passively listening to this literature at the moment, I would like you to note down this information because the names are pretty overlapping. I had already remarked that in tubercular meningitis or in CNS tuberculosis, we call it rich focus, and then there could be a focus in the liver as well. I will also teach you when the focus will develop in the liver towards the end of the discussion, but at the moment I want you to remember Simon's focus, and Simon's focus is not to be mixed with Simon's focus. As I highlighted, Simon's focus is gonna be found in the lung. It is gonna be supraclavicular, but it is gonna be, I'm just putting a small alphabet I to say that this would be an inactive lesion. The active lesion that develops supraclavicularly is called as Puhl's lesion. The basic message is, if a person has been exposed to TB, initially his immunity might catch up, but at a later phase, the bacteria might still be residing in the lymph nodes, might be alive, and they might actually escape from this high security prison and go to the apex and cause mayhem. And that is where this radiological finding will develop, where I highlighted a cavity developing in the right upper zone of this patient, and you can also see a lot of reactive changes and inflammatory changes, and I would say consolidation around the cavity. This cavity can grow in size, can erode into a blood vessel also, and the bad news is then a person can have a high possibility of hemoptysis as well. Now, once we are aware of the fact that adult tuberculosis is mainly going to be a formation of focus in 1 or 2 areas, there's going to be a progressive cavity that will be increasing in size on a daily basis. It can erode into adjoining tissues as well. This is what I said. Suppose this is bronchus, don't draw it at the moment, just follow what I'm saying. Destructive changes. The destructive changes are increasing every day, and one day the cavity becomes relatively so big. The same cavity has now eroded into the bronchus, and inside this cavity are present millions and trillions of Mycobacterium tuberculosis bacilli. Every time this guy will cough, the bacteria will come in the sputum of this person, and therefore this gentleman will become sputum for acid fast bacteria positive. I want to highlight the fact that if the cavity was relatively smaller, mark my words there, if cavity is relatively smaller, then the bacterial load will also be lesser. If bacterial load is lesser, then the person could be having sputum for acid fast bacteria negative. Why I'm highlighting that is because of the fact that we treat both cases, no, sputum for AFB positive and sputum for AFB negative. So I had a query from a doctor saying, sir, okay, fine, you are treating somebody who's sputum for AFB positive. Why are you treating somebody who's sputum for AFB negative? See, in India, sputum for AB negative does not mean he does not have TB. Sputum for AB negative means he has a small cavity. Sputum for AB positive, larger cavity, bacterial load is more. That is why this is happening. So from an Indian perspective, please remember, sputum for AB negative does not mean he does not have TB. It means he has still manifestations, and you need to obviously do some other tests which we will be discussing in the diagnostic algorithm. Unfortunately, our patient did not take care of his health, and now the bad news is that there can be erosion of blood vessels as well. As the cavity will increase in size, it will erode into the blood vessels, and that is where hemoptysis can occur. And usually the source of hemoptysis will be bronchial artery, and because it is an artery, it can even be massive hemoptysis. Now, what are gonna be the symptoms of this guy when there's a cavity formation in secondary tuberculosis? I have highlighted post-primary TB, adult tuberculosis, secondary TB, they all mean the same. This guy was initially having containment, but now the infection is spread beyond it. The manifestations of this guy would be standard fever. That is what I was saying. No, couple of my fellow resident, he actually developed tuberculosis during working because he started having these manifestations. And initially we just laughed it off, and it was only later when he started losing weight that we realized there's something wrong. So there's going to be fever, there's going to be evening rise of temperature. It's not that it's a classical evening rise of temperature, it is just that the person has finished his work, gone back home, because when you're working you tend to focus on work so much that you would not bother about touching yourself and feel that okay, I feel warm, or even if you feel warmish you might still say okay, I'll go home and check. So evening rise of temperature is actually a misnomer, in a sense that person is perceiving his temperature. It might be elevated the whole day long. Along with this, manifestations of night sweats. I mean, that's very first time when my fellow doctor spoke about this that I realized that this is a reality. I mean, he said that I have these cold sweats at night. There was a dramatic loss of appetite, and he was a healthy guy, and he started losing weight as well. Along with this, as I highlighted, if there is going to be a neglect, then bronchial artery can be eroded and the dramatic symptom of hemoptysis will occur. And most Indian patients, they come very late when the hemoptysis component will start, but you obviously can identify the manifestations earlier and handle the patient appropriately. At this juncture, I would also like to highlight the exam aspect that they love to ask, which is massive hemoptysis. I've just sensitized you to the fact that the leading cause of massive hemoptysis is going to be TB. The source of bleeding in this case is going to be the bronchial artery. Magnitude is something in the range of 500 to 600 ml per day. So I've just put a upper limit of 600 ml per day, right? It's a range 500 to 600. So I mean, don't fight about the fact that in some books it is 500. It's a range. Everything in medicine is a range. So upper limit is 600 ml per day. Now, what is the treatment choice for massive hemoptysis is the standard question that he's going to give you. He will obviously make you waste your time by giving a three-liner where he will talk about all the symptoms of tuberculosis, make you think, is it lung cancer, is it tuberculosis? But then you need to pick up these features, because in lung cancer, you could be having multiple other features like Pancoast tumor manifestations, wasting of muscles of the hand, Horner syndrome manifestations, paraneoplastic manifestations. So you need to keep a watch on anybody with fever, cough, weight loss. It could either be lung cancer, or he can start with non-smoker. No, I mean, I understand if it's a smoker it gives more credibility, a non-smoker, and then can talk about symptoms of TB versus lung cancer. So you need to differentiate. Now my point is that if it's gonna be tuberculosis which will have these classical manifestations and there's a massive hemoptysis occurring in the patient, then the treatment of choice would be answered as bronchial artery embolization. I mean, that's gonna be the end point of the MCQ, that he will say what is the main treatment. Your answer is BAE. I also want to highlight that there is a possibility that TB bacteria can not only damage the bronchial artery, but they can damage pulmonary artery also. I mean, that's again a query that I get from a lot of my students, that sir, you said bleed is occurring from bronchial artery. Why not the pulmonary artery? Why is it not rupturing? I agree that any of the two can be damaged, but you see, if you look at the muscles present in the bronchial artery versus the pulmonary artery has relatively more connective tissue. So pulmonary artery wall can also be damaged by tubercular bacilli. But what I have shown here is not a through and through rupture like a bronchial artery, but an aneurysm formation. In fact, this is again a multiple choice question that you guys would have done so many times. The question in the exam was Rasmussen's aneurysm in pulmonary tuberculosis will involve which blood vessel? Your answer will be pulmonary artery. In contrast, bronchial artery will be having relatively, I would say, less support of connective tissue. As a result of it, the chances of it getting ruptured will be relatively high. Sometimes he might even just say that a person is having non-life threatening hemoptysis. You see, not every case which will come to you will be of a massive hemoptysis only. It would be a non-life threatening hemoptysis which this person thought is secondary to that. Maybe he was brushing in the morning, he damaged some tissues, and that is why this blood is coming. I mean, that's the usual thought process of most people initially. If there's a non-life threatening hemoptysis in a patient, he said, what is the first investigation to be performed? On listening to what is the first investigation, lot of guys answered chest x-ray. Then chest x-ray is something that may not be able to visualize the lesion in the parenchyma of the blood vessels. Lot of guys answered bronchoscopy. My point is, why would you do a bronchoscopy right away? Because the surface area of lungs is equivalent to that of a tennis court. Bleeding could be occurring from left, bleeding could be occurring from right, from top and bottom. So navigating through each and every part of the lung will be so time consuming. So how would you know where is the lesion located? You can straight away go in for a HRCT chest, and once you have a CT chest, it can at least give you evidence that there is some lesion present in the lung parenchyma, either in the left side or on the right hand side, upper lobe, middle lobe, lower lobe. I mean, once you know where is the lesion, then you can definitely send in a fiber optic cable, and you can definitely do a fiber optic bronchoscopy, and you can even take a tissue biopsy from the specimen. You can even control the bleeding. You can cause local hemostatic maneuvers there. But the message that I want to give you is, if a question talks about a non-life threatening hemoptysis, or even if it is massive hemoptysis, see, you have less time, so you might even do a rigid bronchoscopy. But for a non-life-threatening hemoptysis, don't jump the gun and answer either X-ray or bronchoscopy, because X-ray won't be able to see anything. Though in older algorithms they used to mention X-ray, but in the current textbook you will notice it is algorithm. They mainly mention HRCT just for localization of the lesion. Then you hit it with help of a bronchoscope. Hit it, I mean, you can take a diagnostic sample. You can achieve hemostatic maneuvers locally, and that will do a lot of good for this person. Per se, what are the advantages of a CT scan? You see, CT scan will basically help you identify whether it is a vascular lesion or whether it is a parenchymal lesion. I mean, you can easily differentiate. And why am I highlighting that is because not all cases would be tuberculosis. Something like vaginal granulomatosis, that would be having vasculitis component, no? So I want to know whether there is a vasculitis component, whether there's a parenchymal involvement, that can be differentiated. The advantage of bronchoscopy is it can directly pick up, like if there is a endobronchial lesion, there is a let me say carcinoid tumor, or any lung tumor eroding into the airway, you definitely can identify endobronchial lesion, take a biopsy, and even initiate local hemostatic maneuvers as well. The usual manifestations of tuberculosis have been highlighted here. I want to add two more words to this, though might look very surprising to you. Don't be surprised if you read about clubbing. Normally, we read about clubbing in cases of cardiovascular system, especially subacute bacterial endocarditis, then in lung diseases like lung cancer or bronchiectasis, but tuberculosis may be having clubbing. Why I'm highlighting it? Because I said that you need to pick up in the question, is it lung cancer? Is it tuberculosis? Lung cancer also has clubbing. The most aggressive lung cancer, small cell does not have clubbing, but adenocarcinoma has clubbing, large cell cancer has clubbing, squamous cell carcinoma has clubbing. So because clubbing is also a feature with lung cancer and with TB, he might try to confuse you by actually writing clubbing in the question, making you have a bias for lung cancer, but then cancer will always have a word written cachexia. And in this case, cachexia as a word is never, I just said weight loss, no, I never said the person is just become skin and bones. Apart from this, another feature can be associated is SIADH, syndrome of inappropriate ADH secretion. So that can contribute to dilutional hyponatremia component. I mean, these are two additional factors which I want you to remember for a presentation of tuberculosis. And once he talks about night sweats, weight loss, loss of appetite, and evening rise of temperature, those classical terminologies, you know that you are dealing with a case of TB. I want to highlight once again that if it is massive hemoptysis, you definitely can go for rigid bronchoscopy, but rigid bronchoscopy is not the solution. It is just method of securing the airway. Otherwise, he will drown in his lung secretions. I repeat that again. If a guy is having massive hemoptysis, there's gonna be so much of blood filling up the airways rapidly that the guy will literally die. So you are basically controlling the airway. You're doing a tamponade effect at the site of the bleed. That's not therapeutic. That is just a palliative measure. You are just saving the other airways. You are saving the person from drowning in his own blood. So, what is the treatment of choice for massive hemoptysis? It's bronchial artery embolization. You will notice I've deliberately not written the word or not highlighted the word rigid bronchoscopy by writing it per se, though I said we will use it because it is a method of airway control. It is a method of preventing rather the flow of blood into other lung segments and drowning them. It is bronchial artery embolization, which is therapeutic, which will save the life of this person. So that step is definitely important. And when they talk about investigations, then obviously, yeah, HRCT chest, fiber optic bronchoscopy in that order are to be done. And you also need to keep a watch on possibility of him talking about Rasmussen's aneurysm. Well, which blood vessel is going to be involved in Rasmussen's aneurysm, guys? It's the pulmonary artery, because bronchial artery is less connected tissue. It can exhibit a through and a through rupture. Next, I would like to highlight the aspect of dissemination of the disease as well. Like earlier, I was explaining that the disease can erode into the bronchial artery. Now I'm saying it can erode into the bronchial vein. Now all the venous return ultimately goes to the heart, and the heart can definitely pump it into the distal circulation. So you would be now having the formation of the next form of TB, that is called as disseminated tuberculosis. And the bad news is that now multiple organs are getting involved. So he can definitely ask you regarding the pathognomonic feature, or one of the most important diagnostic features of disseminated tuberculosis is then remember that your answer would be given as a fundus finding. We usually tend to answer aspects like miliary tuberculosis, or we might say like hepatosplenomegaly. I want you to remember that the pathognomonic feature of disseminated TB, that means there's a hematogenous dissemination, is fundus finding of choroid tubercles. In fact, for this particular slide, I would like to rate this information as one of the important ones, which I've seen a lot of students missing up in the exam. That is, choroid tubercles are the most characteristic or a pathognomonic feature of dissemination of the disease. In fact, there can also be a possibility that the disease can erode into pulmonary artery also, and the pulmonary artery branches into two. So now you can imagine that the disease will spread to both the lungs, and this will result in development of miliary tuberculosis. So I said two types of dissemination occurring. One is into the systemic circulation, second is into the pulmonary circulation. Both can occur, or either of the two is occurring. Both of them are examples of dissemination of the disease. And the peculiar thing about the pulmonary artery dissemination is that when I started with the discussion, I was saying that suppose the Gons focus is in one lung, then that side lymph node will become enlarged. So it was only one side that was getting involved, or even the cavity was getting formed in one side only. But now, as the disease will disseminate, both the lungs of the patient are getting involved, and you would be having this characteristic appearance, which is called as a snowstorm appearance. In fact, from the exam perspective, they love to ask about snowstorm appearance not only in an entrance exam, but even if you are applying for junior residency, that is non-academic post, lots of times snowstorm appearance X-ray might be given to you, and they might ask you, okay, tell me the 5 differentials of snowstorm appearance. Obviously, tuberculosis is easy, but I want you to remember that the commonest occupational lung disease in India, silicosis, then would be chickenpox pneumonia. Well, chickenpox per se in older age group can contribute to this manifestation. Then would be pulmonary hemosiderosis. I'm not saying hemochromatosis, I'm saying pulmonary hemosiderosis. Then is pulmonary alveolar proteinosis, which is discussed subsequently in the app. It is a disorder where the turnover of surfactant is affected. The surfactant is produced, but it is not destroyed. And even fat embolism syndrome, FES, though it's rare, but then I've just included that. So though the list is very exhaustive in radiology, these are 5 minimum causes that I want you to remember for the miliary picture slash the snowstorm appearance that they love to ask in a routine interviews, because as such this radiological finding can be relatively common. Lots of time people have misdiagnosed this miliary picture as even a bat wing edema, but then bat wing edema should be having cardiomegaly. There should be bilateral pleural effusions occurring in a patient. I mean, the hazy whiteness that is present, I agree, can contribute you to think in terms of possibility of pulmonary edema, but then you need to collaborate with other radiological findings that can be encountered in patients of heart failure as well. I will now focus on a different chest X-ray that I had shown initially also, where there is a cavity formation. I'll just mention a finding here, like suppose this is bronchus and this is cavity. Now, when air will travel into this cavity, then there can be a very characteristic breathing pattern present, which can itself be a multiple choice question. You would have done this MCQ that amphoric breathing, like I have taught you, bronchial breathing is a characteristic breathing pattern in pneumonia. Similarly, at the moment I'm teaching you regarding amphoric breathing. Well, I would like to highlight the fact that the sound of amphoric breathing is like if you blow over an empty bottle of Coke. Like you take any bottle, like a glass bottle of Coke empty, and then you blow air over it. So the sound that would come, that is the kind of sound that would be heard with respect to a cavity once air enters into it. And sometimes a distinct phenomenon might occur that the pus might actually occlude, or airway secretions might occlude the opening of the cavity per se. Now you will ask the patient to cough. When the person will cough, then these secretions will be dislodged. And the moment the secretions will be dislodged, once again the air will rush inside. I repeat the fact, I said there is a sputum plug or airway secretions present at the entry of the cavity per se. Because there is a occlusion present, you ask the person to cough. So the cough will actually cause dislodgement of the sputum and air will rush into the cavity. So another auscultatory finding that they can actually ask you with respect to a cavity is called as post-tussive suction. So what I'm saying is that if you are not able to pick up a cavity on a chest X-ray, understandable, you can still remember these findings that I've highlighted. 2 findings I've said with respect to a cavity: amphoric breathing and post-tussive suction. I repeat once again, amphoric breathing would be as if you're blowing over an empty bottle of Coke. Post-tussive suction, the name itself is explanatory. Post-tussive, after coughing, air is being sucked inside. So that's why I've drawn a thicker blue arrow here, that the sudden gush of air into the cavity, which results in the sound called as post-tussive suction. There are two important agendas that I want to highlight, with the most important one: choroid tubercles are a fundus finding in disseminated tuberculosis. Dissemination can occur into pulmonary circulation, dissemination can occur into systemic circulation as well, and then gradually other organs can also get involved, like brain can be involved. Therefore, tubercular meningitis will ensue, and that would result in a rich focus developing in the patient. In fact, they love to ask about extrapulmonary TB, so I would like to highlight that the mnemonic that you can remember for the sites of extrapulmonary TB which are common frequently asked is LPG. What I mean by LPG is alphabet L would stand for lymph nodes getting involved. After lymph nodes, it is the pleura that is involved. Please appreciate, pleura would be classified in extrapulmonary TB and not in pulmonary TB. By pulmonary mean parenchymal involvement, and then it could be genitourinary tract involvement as well. Well, you read about putti kidney, you read about gall for ureter in urology, in surgery also about them. It is LPG, the mnemonic L, lymph nodes, pleura, and then genitourinary tract are the sites of extrapulmonary TB, with obviously cervical lymphadenopathy being common, and you can definitely do a FNAC and if required even a CB NAT on the sample. When it comes to pleural tuberculosis, the best way to confirm the diagnosis would be to perform a pleural biopsy and then do a CB NAT on the biopsy specimen. You see, when I started the discussion, I said pleura can be involved even in primary tuberculosis. When I was teaching you Gons focus, I said there is a possibility that it can be subpleural and therefore pleuritic chest pain can develop. So even in primary TB, you can be having pleural involvement. Even in secondary TB, you could be having pleural involvement. Obviously, because as the cavity will expand, tubercular pneumonia will progress, you could have problems. And now I'm teaching you that even in extrapulmonary TB, pleural involvement has been discussed. The clinical features will be straightforward of a person having fever, weight loss, evening rise of temperature, night sweats, and then we'll talk about specifically pleuritic chest pain, or he might just mention about auscultatory finding of pleural rub, which will be auscultated on deep inspiration in the patient. Since he's having a pleural effusion, you decided to do a diagnostic thoracocentesis in this person. On diagnostic thoracocentesis, which must always be ultrasound guided, you notice the following facts: that the fluid was relatively yellowish in color, that is straw. It was having preponderance of lymphocytes. When you will look at the sugar in the pleural fluid, it will be relatively low, though low sugar in pleural fluid could be suggestive of even a malignancy, but even in tuberculosis the values would be on the lower side. Proteins will definitely be elevated because after all it is going to be an exudate. And then there's going to be elevation of an enzyme which they love to ask, adenosine deaminase. In fact, this is the reason why I've gone into this slide. Adenosine deaminase levels elevated in the pleural fluid are suggestive of diagnosis of pleural tuberculosis. But if he says what is the investigational choice for pleural TB per se, then don't answer adenosine deaminase levels. Do not answer CB NAT on the pleural fluid. I want to do a pleural biopsy. Now, obviously, patient may not agree for a pleural biopsy. Whatever fluid that I have, I can do a CB NAT on the same as well. But the diagnostic yield in pleural fluid can be lesser as compared to the diagnostic yield in the pleura per se, where the infection is present. I repeat the fact once again: CB NAT of the pleural fluid and CB NAT of the pleural biopsy specimen, both are very closed options, because the usual query that I will get is, sir, after all the fluid is being produced from the pleura only, it's a reactive fluid, so why not? The point is seeding of bacteria is occurring in the pleura and there is a fluid that is being produced subsequently, so that fluid may not have TB bacilli sometimes. It is a reactive fluid after all. So we need a pleural biopsy specimen. Obviously, if a person does not provide us or does not give consent for the same, then obviously you will use the same pleural fluid and confirm the diagnosis of the patient. And lots of time in government hospitals, because TB is so common, we even start empirical treatment. Lots of time you will say reports will come later, but in tubercular meningitis we are starting ATT in our patients even before the CB NAT CSF is coming, because the clinical features are matching the features of tubercular meningitis. So I mean, this is ideal scenario, but lots of time empirical treatment is given regularly by us. The next agenda that we will cater to would be if a person is having concomitant HIV with tuberculosis. The first and the foremost thing he wants to know is that, do you know what will happen to the size of the cavity when both the diseases are concomitant? The usual impression is that in a person with HIV with TB, the cavity will be bigger, but that is not the case. You see, cavity is produced when there is a fight, and in this case there will be less fight because immunity is lesser. Cavity size in HIV with TB is surprisingly smaller because there is no fight occurring. Because the cavity size is smaller, therefore if you're gonna do a sputum examination The sputum for acid-fast bacteria will turn out to be negative because, as I explained to you, small cavities could be actually having less bacterial load. That also tells you the fact that child may not transmit TB to another child because cavity size is smaller in children. So child-to-child transmission of TB is not seen. It is usually adult to a child transmission. Because the immunity of the person is low, therefore the Mantoux test might turn out to be even false negative. Because the cavity is very small, therefore chest x-ray will turn out to be normal. What I'm trying to teach you is that because cavity is smaller, the tests which we check are usually turning out normal, and Mantoux is lesser because immunity is also compromised. In these circumstances, how would you diagnose the disease? So the problem in HIV with TB is that it is not pulmonary TB that is more common, it is rather dissemination of the disease which is relatively more. So since dissemination is increased in the patient, it might spread to distant tissues, it might spread to the brain. So we can be using various body fluids. Obviously the investigational choice for diagnosis or disseminated would be CBNAT. Now you will be doing CBNAT on the CSF sample if it disseminates to the brain, or we can even use gastric lavage. We can use various body fluids for diagnosis of a patient who's having tuberculosis and HIV simultaneously, and where the lung investigations may not yield you very significant information. Now, once you have made a concomitant diagnosis, and anyway you're aware, no, when in AIDS patients CD4 count will decrease to less than 500, tuberculosis anyway comes in. We have discussed when the count goes down to 200, zero VC would come in, less than 100, cerebral toxoplasmosis will contribute to seizures, and less than 50, there can be cytomegalovirus retinitis or Mycobacterium intracellular. I'll write down the data subsequently, but if you document low CD4 count, anyway, the incidence of tuberculosis will rise, and in fact, a full-blown tuberculosis could occur. Now you have to give ATT to the patient also, and combination antiretroviral therapy, and here problem will start again. If a doctor is gonna start, if you initiate combination antiretroviral therapy in this case, if you initiate combination antiretroviral therapy in this case, then there can be rather upgrade of immunity. The upgrade of immunity will rather produce cytokines, and these cytokines can cause high grade fever, and your patient might actually curse you saying, sir, I was better before the treatment. Your patient is refusing to come again for consultation. Why? Because he thinks that you're not giving the right treatment. Because imagine if I write you a medication and you get high grade fever and think you are a non-medico. If I write you a medicine and you get high grade fever, being a non-medico, what will you think? The doctor's medicine has produced some reaction in me. Lots of patients of AIDS with tuberculosis, if you start AIDS treatment first, the immunity is upgraded, but the cytokines which are produced will actually cause a dropout of the patient, poor compliance to continue with the medication because he thinks doctor has given me a medication which is causing a reaction. This iris is actually called as immune reconstitution inflammatory syndrome. And lots of time this concept has been asked in the exam that if a person is having concomitant AIDS with tuberculosis, what treatment should be given first? Then your answer is first give ATT to decrease the bacterial load. After 2 weeks, you will introduce combination antiretroviral therapy. When I was a student your age, they used to do ulta, and that actually resulted in patients not coming to us for follow-up, or rather be lost to follow because they used to develop fever, etc. And they used to think that our medicine is causing a reaction. So we doctors also have a learning curve, and we soon realized that we should not be giving AIDS treatment first, and this has been extensively asked in the exam, and I've discussed it even in the AIDS section, that in a case of, I repeat that fact again, in a case of AIDS with TB, first give ATT, decrease the bacterial load, and then give AIDS treatment after a gap of 2 weeks. The reversal can contribute to iris immune reconstitution inflammatory syndrome. Another aspect that I wanted to remember for HIV with TB would be with respect to rifampicin. Please remember, rifampicin can exhibit a drug interaction with protease inhibitors, which are one of the main weapons which we are using to fight the HIV infection. Now, because of this drug interaction, we will have to drop either of the two. I cannot drop protease inhibitors definitely, so I have decided to drop rifampicin. But if I drop rifampicin from the protocol of treatment of tuberculosis, I'm losing my firepower. To compensate for the lost firepower, what drug will you use? The pharmacologist would have also taught you it is rifabutin. So remember, in HIV with TB, rifampicin is contraindicated. What is indicated? Rifabutin. If he says why, it is the interaction with protease inhibitors. I'll just summarize some of the important facts that I've taught you for primary TB, post-primary tuberculosis, extrapulmonary TB. I will introduce a new concept here also, that is congenital tuberculosis. In fact, it is a very surprising term that a baby is being born with tuberculosis. I mean, this looks shocking. But it's true, because if a mother is having active lesion anywhere in her body, then that infection can spread hematogenously to the baby. How? Via the placenta. From the placenta, it will go via the umbilical vein, because umbilical vein provides oxygen to the baby, and umbilical vein drains where? Liver. So they have asked in the exam, in a case of congenital tuberculosis, what will be the site of Ghon's focus? Please remember, the infection will travel via the placenta, via the umbilical vein into the liver of this little baby. So in congenital tuberculosis, the site of Ghon's focus is liver. In primary TB, I was teaching you that it is gonna be the lower part of the upper lobe. In fact, that was the first diagram that I actually drew before you. Then in secondary tuberculosis, it was the apex. Lots of times secondary TB is written as post primary TB, and people just miss the word post and start talking about or start answering from primary TB perspective. Careful reading is of big importance in the exam. Lots of time we miss out words which actually changes the entire domain. When it comes to a case of extrapulmonary TB, I have already explained to you that it is the cervical group of lymph nodes that will gradually become enlarged. Then can be pleura also. I have also highlighted that if it's gonna be disseminated tuberculosis developing in a person, then one of the highlights is a fundus finding. Well, what is the name of the fundus finding? I hope everybody can remember, right? That would be a choroid tubercles developing in the patient. So in disseminated TB, obviously, it could be hematogenous dissemination via lungs, hematogenous dissemination into systemic circulation. So obviously the domain will change, because when I'm talking about lungs per se, it would be a miliary picture that would be developing. I've also highlighted that in a case of concomitant HIV with tuberculosis, the bacterial load is actually lesser. I mean, the pulmonary manifestations are lesser and the chances of dissemination to the brain is relatively more. So CNS TB will be more common in people having HIV with AIDS. With respect to AIDS per se, since the CD4 counts will begin to reduce, there can be some infections. In fact, since I have said this verbally, question to you guys at the moment is, and you need to spot on me with the answer, can you tell me a atypical mycobacterial infection when CD4 count is less than 50? Well, I think most of you would have guessed it right. It is MAI, Mycobacterium avium intercellare is a atypical mycobacteria that is usually going to be seen when CD4 count is less than 50. Person can go blind because of cytomegalovirus retinitis, where you read about Pisa pyeretinopathy. Less than 100, there could be seizures because of development of cerebral toxoplasmosis. Site of cerebral toxoplasmosis is basal ganglia, only limited lesions in the area of the basal ganglia. Less than 200, it is Girovesi. For this, we can use gamoremethamine stain to be put on the bronchoalveolar lavage of a person of HIV or TB with the following low counts. And I've talked about Girovesi in the infection component, lower down in the app. Less than 500 is anywhere tuberculosis. These are some very common infections which are seen with HIV and AIDS with concomitant tuberculosis, so should be known to you. I have also enumerated multiple times what are the sites for Ghon's focus. So let's just make a quick list here. Obviously, the lung would be an answer, but even lymph node can be answered. In fact, specifically for cervical lymph node, your answer would be given as tonsils, because the seeding of bacteria will occur in the tonsil, and then there would be a cervical lymphadenopathy developing in a person. Another site can be ileum. Now, how will ileum get involved? There are two ways. One method can be that he is swallowing. You see, if he is having pulmonary TB, the bacteria will come in the sputum and he will swallow his sputum and it will go travel to the small intestine. So one possibility is swallowed sputum, which is containing acid-fast bacteria. Second can be a problem in rural India, because you see there is a practice of consuming unpasteurized milk. People might drink milk without boiling. That is, Mycobacterium bovis can also seed the ileocecal area, causing obtuse ileocecal angle, or it might result in even a stricture formation. Then I've highlighted even the liver can be involved in cases of congenital tuberculosis. The infection will come by the umbilical vein to the baby. So these are a couple of sites where Ghon's focus per se has been highlighted, and in each of these areas then the reactive changes in the form of lymph node enlargement, then calcification in the form of containment will occur, and especially in the lungs there is a possibility of dissemination to the apex. I highlight once again, guys, Pujols is gonna be active and Simon is gonna be inactive. So per se, if he says supraclavicular lesion in the exam only, no, he does not mention active or inactive, then the primary answer is Pujols, because we are basically talking about disease manifestation, not the later part of the disease but the initial presentation of the disease. So those words are definitely to be remembered and you will be able to answer things better. The topic of tubercular meningitis per se, I have discussed separately in meningitis part 2. So if you scroll to the neurology component, go to meningitis part 2, where tubercular meningitis and its associations have been mentioned. I have spoken about the routine stuff, no, malnourished child, BCG vaccination not given, and then he is having contact with a case of tuberculosis, illness of couple of weeks, CSF lymphocytosis, cobweb coagulum. There are going to be so many pointers for tubercular meningitis that it is very hard to miss. And anyway, in Indian exams, CSF lymphocytosis with a long history always is in favor of tubercular meningitis per se. I shall now be explaining to you regarding a workup of a case of pulmonary tuberculosis. If they ask you what is the best test for diagnosis, then the test to be done on the sputum would be CBNAT, cartridge-based nucleic acid amplification technology. You will notice that in Western books like Harrison, they have not used the word CBNAT, but are using the word gene expert. So I want you to remember that gene expert and CBNAT basically mean the same. Now, before I summarize, where are you gonna order a CBNAT? Because you see, you need to obviously use the common investigations, that is a sputum smear for acid-fast bacilli and a chest X-ray. So I'll create some permutation combinations before you so that we can work out, what are the scenarios that you will commonly encounter. Alphabet S will stand for smear status, XR will stand for radiological status. One of the easiest case for any doctor to diagnose will be where the sputum is also turning out to be positive or smear positive, X-ray is also turning out to be positive. So I can say that this guy is a microbiologically confirmed case of tuberculosis, and therefore I can initiate ATT in this patient for a duration of 6 months. The bottom line is that if sputum is positive, even if the X-ray is turning out to be negative because the cavity is relatively moderate size. So in those circumstances, it may not be visualized on a chest X-ray. In both these scenarios, you will say that I am treating a case of microbiologically confirmed tuberculosis. However, the problem for any doctor would be that if sputum is turning out to be negative, but X-ray is showing, let me say, a patch of what looks like a tubercular pneumonia, you obviously need to confirm the diagnosis that yes, it is caused by tuberculosis and not any other organism. This is where the role of CBNAT on the sputum will definitely come. So I want you to remember the first indication for performing a CBNAT on the sputum, which is going to be answered by you as a person in whom the sputum report is turning out or the smear report is turning out to be negative, X-ray is turning out to be positive. Another case scenario possibility is that smear is negative and the X-ray facilities are at the moment not available, but at the same time clinical suspicion is very much present, like this person is having the traditional features of weight loss, evening rise of temperature, night sweats, and maybe even a contact with the open case of tuberculosis. In those circumstances, again, CBNAT would be done. Apart from this, I also want you to remember that CBNAT can be directly ordered in a person who's a person living with HIV. In fact, this is from PSM domain. Any person living with HIV, when the CD4 counts are gonna be decreasing, then definitely once the CD4 counts come to less than 500, the incidence of tuberculosis will definitely increase. Next is a patient who, let me say, was a dropout and he actually disappeared from the scene. Like he was living in a village, he was taking the DOT treatment, and now he has disappeared. He did not even take treatment. Maybe he went for a job to some other place, and he has come back. He's again having symptoms of TB. So you see that if a person is not going to be compliant and he's not going to be regular in taking treatment, then multi-drug resistance can definitely come in. Or let me say, you are giving the treatment and still is not improving. So you are suspecting MDR TB. MDR TB can be suspected in two scenarios. One is a HIV positive patient. MDR TB can be suspected in non-compliant patient. So what I'm saying is this is obviously at the discretion of a doctor when he will suspect MDR TB. But if it is, then obviously CBNAT will be advantageous. Why? Because CBNAT not only will diagnose the disease per se, but also can tell you about resistance to rifampicin. There can be three possibilities in this case. They can be rifampicin sensitivity, they can be rifampicin resistance, or there can be an indeterminate status as well, which I've written as alphabet I. If it's going to be rifampicin sensitivity, no issues, then it is obviously as good as saying that you have demonstrated that person is having Mycobacterium tuberculosis as the incriminating agent for the lung disease. If it is resistant, then obviously the resistant protocol has to be brought into picture. But if it is going to be an indeterminate status, one option before us is to repeat the CBNAT report of the patient once again. And second, he can definitely here love to introduce the liquid culture. I'll mention the various types of liquid cultures that are available, but you're familiar and aware from microbiology that BACTEC is one of the important ones. This flowchart is actually given in PSM books also, so I'm very sure that you have already gone through it. I've just created permutation combination. So I would just suggest you to, just note them down, the 4 permutation combinations, both positive. Sputum positivity is there, then there is absolutely no problems. It is sputum negativity where CBNAT per se will have a role. So let us now summarize what are the conditions and what are the scenarios, and I'll add to what I've just told you. Some of the scenarios I've already told you, but over and above this, I will add some more points where CBNAT should be ordered. The first scenario would be a person living with HIV. He's deteriorating, he's having a lung disease. So I would definitely like to do this test. Obviously, if the CD4 count will decrease further, then even zero VC infection will come in. But tuberculosis is one of the early ones, especially common in our country. The next two scenarios are what I discussed with you. A patient is turning out to be smear negative. In one case, the X-ray facilities were not available. In the second scenario, yeah, X-ray is definitely showing a patch or a lobar inflation or a segmental collapse or a consolidation. I mean, if I'm suspecting tuberculosis in a person, then definitely I should be doing CBNAT in this scenario. Then is MDR settings. I have already highlighted MDR settings would be common again in AIDS positive patients and would also be encountered in patients who are relatively non-compliant and now having recurrence of symptoms, or even if you are treating a case is not improving, you can again suspect MDR in a patient. Now, the additional point that I want to make here is, and that is the reason why I have summarized the findings of CBNAT here, or indications for performing a CBNAT here, is extrapulmonary tuberculosis. You see, when I say extrapulmonary TB, like for example, if person is having tubercular meningitis, then I can be using cerebrospinal fluid. So the basic point is CBNAT will still be done, but instead of doing it on the sputum of the patient, in this case it is the CSF sample on which we will be testing. Another additional detail is if a person is having pediatric tuberculosis. Now, there is an algorithm for pediatric TB also that you can read from pediatrics or from PSM domain also. But let's have a look at some of the important aspects that you universally need to know. You see, you have to suspect tuberculosis in an Indian child who has been having this low-grade fever persistently for a duration more than 2 weeks, along with unremitting cough. I have already explained to you that child cannot transmit TB to another child because the size of the cavity is relatively smaller, but then the progression of the lesion will definitely occur in the body of the patient, and because there's a cavity developing in the lung, there's a destructive process occurring in the body, so catabolic processes will also be I would say upgraded, and therefore weight loss can be seen. The magnitude of weight loss which is important in pediatric tuberculosis is approximately about 5% decrease in weight over a span of 3 months. Now here I want to clear before you that lots of you might be saying, sir, we have read 10%. So first I would like to clear what does Harrison say for the word involuntary weight loss. You can very well understand I'm talking about a person who's not doing any crash dieting, not on a keto diet, not doing any workup, but is still losing weight. So when you say involuntary weight loss with respect to adult, and please listen to this very carefully, in Harrison, the chapter of involuntary weight loss in volume 1 begins by what I'm saying. He says it is a 5% decrease in the weight of a patient. But please remember, in this case, the 5% decrease in weight is over a span of 6 months. I want to highlight the fact that the cutoff is, the duration that he's taking is 6 months. And then what about 10%? Well, Harrison does not mention the word 10%. He rather says 10 pounds. You see, in America or Western countries, they don't follow the kilogram system like us. They measure their weight in pounds, right? So it is written as 10 lbs. That means 10 pounds. So you will notice the fact that there are two definitions given. One is going to be 5% decrease over 6 months. Second is 10 pounds decrease over 6 month period. For adults, the denominator for time frame is 6 months. Pediatric case I mentioned was 3 months. And the question then still comes up. Sir, I have read, lots of you will say messages or send me messages saying, sir, I've read 10%. Then where have you read that 10% is for category B symptoms? And category B symptoms is what you deal or read with Hodgkin's lymphoma. When you read the table of Hodgkin's lymphoma, you will read about category B symptoms. That is where the word 10% comes in. So I would not suggest to answer 10% as the primary answer in adults. Why? Because that is valid only for a case of Hodgkin's lymphoma. This is separate. There are so many causes for involuntary weight loss. No, it can be lung cancer also, not necessarily Hodgkin's lymphoma. So I would suggest in the exam, if they ask you what is the magnitude of weight decrease that you should suspect IWL, involuntary weight loss, it is 5% over a duration of 6 months and 10% over a duration of 3 months or something like that. That's valid for Hodgkin's lymphoma, and even in pediatric case you will notice it is 5% over 3 months. At the moment when I'm speaking, you might be very, I would say dazzled by the amount of percentages that I'm saying before you. You will say, sir, itni sari percentages, how do you expect us to remember? I agree to that, but at least we can come to one basic conclusion. In both pediatrics and adults, it is 5%. It is the duration magnitude that is changing. For pediatric cases, it is written 3 months. Smaller, bachcha chota hai, right? So 3 months. Adult, it's gonna be 6 months. And when it comes to 10, it is not 10% in adults. It is 10 pounds over the same time frame. I shall now be explaining to you regarding treatment of a case of pulmonary tuberculosis. When I was a student at your age, I used to read actually 4 categories, but you will notice that now they have merged all of them together and there's a single category in which all the cases would be treated. In the exam, if they ask you, and I know this is overlapping with PSM, but you can listen to me at 2x here, that in any newly diagnosed case of tuberculosis, whether he says that the person is smear positive or whether he says the person is smear negative, both cases have to be treated. I've already sensitized you to the fact that in an Indian scenario, smear positivity means a big cavity, smear negativity means a relatively small cavity, so the cases definitely need treatment. When I was a student, I used to read that if a person is having, or if he used to use this nomenclature, previously treated case. You see, we used to use streptomycin injections for these patients and they were extensively used all these years. But then we saw that it was not yielding the desired results and the efficacy was same if you repeated the same course once again. And even the ototoxicity component that comes with streptomycin was I would say a debilitating factor. So as of now, the government of India has withdrawn those streptomycin injections which were notorious for causing deafness in patients. And if you go out in the periphery in PSN postings, you will actually come across patients with tuberculosis who actually became deaf because of the streptomycin administration in indiscriminate amounts. So now, even in a previously treated case as well, instead of saying category 2, it is still category 1, and the same 6-month treatment would be given. That would be 4 drugs initially for 2 months. Isoniazid, rifampicin, paracetamol, ethambutol, and the next three drugs for the next 4 months in the continuation phase. In fact, the query before you guys from my side at the moment is, why are you combining so many drugs? When I ask this question per se in I would say a regular face-to-face class, the usual answer I get is, sir, we are giving so many drugs because we want to prevent resistance. I want to tell you that is not the case. You see, I'll just say some baseline data which I want you to listen to here so that you can understand why are you using so many drugs. Let me say, if this is a cavity, inside this there would be millions and trillions of bacteria because lots of oxygen is present here, and therefore the bacteria which are present in the cavity per se are called as fast growers. However, there would be some bacteria in the interstitial space. In the interstitial space, there will be relatively less oxygen, so they are relatively called as slow growers since the multiplication rate would be lesser in a counter deficiency of oxygen. And some bacteria would be trapped inside the giant cell, like I've shown a giant cell, and inside that the TB bacteria are present. So in this case, in a hostile environment, the growth will even be lesser, so they're called as spurters. Now, please appreciate that if I want to kill the spurter, I will have to give a drug that will go inside the giant cell no, and kill it. So which drug will be having an intracellular action? The answer is pyrazinamide. Whereas if I want to kill the slow growers, then I need a drug that has a high volume of distribution because interstitial space will have very less blood supply. So to reach the interstitial space, I need a drug having a good volume of distribution. And for fast growers, I would be requiring rather a drug with a high bactericidal killing activity, that is isoniazid. So the reason why we are combining the drugs is not because of primarily preventing resistance. The primary reason why we are combining the drugs is because we are acting on the different species of tuberculosis bacteria. They have different multiplication rates at different sites inside the cavity, interstitial space inside the giant cell. And you can see why is the logic of combining three bactericidal drugs is present here is mainly because you want to act on these different species per se. And once I give this treatment, yeah, along with the ethambutol, which has a bacteriostatic activity, I will be able to treat the patient very effectively. When it comes to patients who have been previously treated, additional aspect which always has to be kept in mind is drug sensitivity testing, because they can definitely develop rifampicin resistance. An MCQ asked in the exam, which one of my students shared with me, was that they asked the gene which is responsible for rifampicin resistance, that is called as RPOB gene. The learning for us is streptomycin was causing ototoxicity, so we have got rid of it. We are now treating the case as a case of newly diagnosed case of pulmonary TB only. That's the standard regimen for 6 months. intermittently Government of India also make it thrice a week treatment, but again the compliance rate became relatively lesser. People became casual because one day they had to not take the medicine and not go to the dot center, so they stopped going the next day as well. So they said that take it on a continuation basis. Anyway, these are policy issues that uh, do not have any therapeutic importance. It is just that compliance is very important for management of these patients. And if a person is non-compliant or he is having simultaneously development of HIV, then the setting of MDR can definitely occur, for which the treatment will be relatively expensive. In the initial phase of the treatment, alphabet L here would stand for levofloxacin. So we are using second line drugs here, that is fluoroquinolones. Alphabet K would stand for kanamycin. So second line drugs are, anyway you are familiar with them from even your pharma classes, but it's my job to actually just mention the regimen which is commonly used, because there are so many of them given in the book. ET would stand for ethionamide. CS would stand for cycloserine, Z is understandable pyrazinamide, and E would stand for ethambutol. So these are the molecules which would be given to the patient for the initial 6 months. The total treatment of a MDR tuberculosis will extend over 2 years. So let's look at what drugs would be given over the subsequent 18 months. I'm just putting a cross here to say that kanamycin will not be used, pyrazinamide will not be used. So what is going to be used? Levofloxacin, ethionamide, cycloserine, and ethambutol. So I would just suggest you to just note this common regimen down so that you are able to answer accordingly. And the minimal duration of treatment in MDR TB actually happens to be 2 years, and that's why the cost factor also comes in. Now it will be my job to explain to you that in India we are having a spurt suddenly in cases of XTR tuberculosis. Well, the definition of XTR tuberculosis would be the patient will be having resistance to both first line as well as second line drugs. That is, resistance to one of the main weapons that we have, isoniazid rifampicin. Along with this, there will also be resistance to fluoroquinolones. That's going to be molecules like levofloxacin or ofloxacin. You would notice mainly levofloxacin is the one that is used, and once a day tablet is more than sufficient. Along with this, person will be having resistance to any of the three injectables that I'm going to write here. So SLI means that we are having resistance to any one of the three second line injectables. These second line injectables can be remembered as ACK. Alphabet A would stand for amikacin. Again, the advantage of amikacin is once a day shot that is required. Then C would stand for capreomycin and K would stand for kanamycin. I want you to remember the definition of XDR-TB, which is going to be resistance to first line drugs, second line fluoroquinolones, as well as second line injectables as well. Now, once you're going to be having a case of XDR-TB, again, you are stuck because you need to treat this patient. And sometimes the treatment here might go up to as much as, shockingly, 2.5 years. So what are the drugs that are going to be used in this case? Well, I'm just going to enumerate those drugs. The mnemonic that you can use is 3 C's, 2 E's, and PUB. PUB looks still, a little casual word, but 3 C's and 2 E's. We just need to figure that out. Alphabets T would stand for capreomycin. Then would be cycloserine, and the third C that I want you to remember here is clofazimine. That's the same drug that we are using even in treatment of leprosy and can cause red tears, or it can cause red discoloration of urine. You're aware of the fact that orange discoloration is seen with rifampicin, but the red discoloration can be seen with clofazimine, which might even look like hematuria sometimes. Alphabet E here, the two E's are ethionamide, and the next E I want you to remember here is ethambutol. Ethambutol, guys, is the bacteriostatic drug that is metabolized by the kidney. So lots of time we might say person is having concomitant renal disease. What drug would you not like to give? Ethambutol. Whereas the primary drugs isoniazid, rifampicin, and pyrazinamide are metabolized by the kidney. Alphabet P will stand for pyrazinamide. The advantage of pyrazinamide is that it has an intracellular action. It is again a bacteriostatic antibiotic. And then I want you to remember a drug which is extensively taught in pharmacology also, that is bedaquiline. The duration of treatment with the following drugs would be at least for approximately 6 to 12 months. And then we will have to continue with some more drugs for a total duration of 18 months. So you can very well see that the cost of treatment will definitely go up or will dramatically increase. Let me just write down the remaining drugs as well, just for the sake of completion. If you can remember them, great. Otherwise, at least try to remember the treatment, the standard treatments for MDR tuberculosis that I've discussed with you. It is ethionamide, cycloserine, then would be clofazimine. the same drug that is used for management of leprosy. And you are now aware, no, that in leprosy, both in paucibacillary and multibacillary, we are using equal amount of drugs. It is only the duration that has changed. So because these changes keep on happening, that is why national health programs are obviously important. The next drug that we're talking about here is linezolid, and then would be ethambutol. The message is that for extensively drug-resistant tuberculosis, the treatment might go up to as much as 2.5 years as well. And then there's a new scheme on the part of the government that is called as DOTS 99 scheme. In DOTS 99, you would have seen that when the person will take out the tablet, there will be in the strip a toll-free number displayed, and the person will have to then call up on the toll-free number, so that you are using technology to actually identify or rather realize that person has actually consumed the tablet or not. I mean, what we are trying to check here is the compliance part. So obviously you have DOTS 99 technique, which is usage of technology to actually check out the compliance of the patient. A lot of things that I've said in the last might be actually having an overlap with PSM as well, but I definitely would like you to remember the aspects. For category 1, the aspect is no big deal, everybody knows about it. But yeah, he started asking about MDR tuberculosis. He started asking definition of XDR-TB. So you guys are anyway familiar with it, and the treatment part can be revised, and especially the side effects of these drugs can be revised from the pharmacological domain as well. Thank you so much for hearing me out.